Okay, well, welcome to the second last session of the course. I'm pretty excited for Amira to tell us about other domains of medicine. There's a bit of a surprise in there, but I'll let you figure that out yourself. Okay, but before that, like I mentioned, this session's lecturer is Dr. Amira Aissiou. She's a family medicine resident. If you're looking for a family doc in a couple years, you can go to her. She's also the co-founder of the AI and Medicine Student Society, and my very close friend and colleague at the newly minted AI and Medical Systems Society. So with that, I will give it away to Amira.
Awesome. Thanks, Hassan. I'm just going to set up here, so just bear with me. Okay, I think this is okay. Everyone can hear me, right? Okay. Hi, everyone. So the other domains of medicine is going to be family medicine. Okay. So thanks for the intro, Hassan. Hopefully we're going to finish a little bit early today. If you haven't already tracked your attendance, please do so you can get credit. So this is called Other Domains of Medicine. We're also going to look into how to read an AI or ML paper in medicine specifically, just because the approach is a little bit different than your usual AI ML paper. So I just want to know, like, are you guys in computing sciences or medicine? Like, who here is more like medical side? Okay, who here is more computing sciences side? Okay, and who's neither of those things? What are you guys in? That's medicine. Okay, cool. Nice to meet everyone. So for other domains of medicine, I really wanted to put an emphasis on primary care. And the reason I'm putting this emphasis is because I'm trained in primary care. And also, in a sense, primary care is a little bit of everything. So there are lots of people involved in primary care. When we're thinking about doctors, we're really talking about the family physicians and the general practitioners. As you know, in Canada, we have a socialist health system. So we're trying really hard to find other ways to get people care without actually having to see a family doctor because we are so short on family physicians. So it's really a multidisciplinary team when we're talking about primary care. It's not just family doctors, it's also nurses and nurse practitioners. We have dietitians and nutritionists, physiotherapists, athletic therapists, community respiratory therapists for the COPDers and the people with asthma, community social workers, and so many more. So everybody kind of has to work together to provide the best care in the community for a patient. The way Alberta is trying to structure things is to get people to have a patient medical home. So who here has a family doctor right now where you can say, I definitely have a family doctor that I can go to? Okay, so it's like 50% of you, which is kind of like the reality in Alberta. There's lots of people who don't have a family physician, and we're really short of family physicians. But ideally, what we are trying to do is get everyone to have some sort of medical home. So this is the person or the place that you would go to for any situation. And from there, they can either refer you to a specialist or they can start you on a management plan. One of the really big advantages of being in primary care is that you're very involved in preventative medicine. And again, in a socialist system, which is our healthcare, we really want to prevent illnesses before they come. That's the most financially efficient thing to do, and also prevents a lot of suffering. There's also a lot of data in primary care, again, because we're involved in everything. So when we're thinking about things like preventative medicine, taking a whole patient into account and seeing what they do during their day, what their genetics are, what their other comorbidities are, would be very helpful in risk stratification and preventing all the things that we see today, like heart disease and stroke and all those great things. So some potential uses of AI in primary care. Again, it's that risk stratification component. We want to prevent diabetes from happening before it happens. We want to prevent strokes from happening before they happen, and any other disease. There's also a huge area of remote monitoring that's being developed. Of course, the ecosystem right now is being taken over by the big people like Apple and Google and Microsoft, who are developing their own technologies to monitor people remotely. Now, this is a really big deal because our hospitals are jam-packed right now. It's like any hospital you go to, there are almost no beds at any given time. And that's why people are staying in the ER for so long, because everything's so bed locked. So there's this huge push to get people outside of the hospital and back into the community. And what they say when they push people out of the hospital is follow up with your family doctor. And if a patient is not well enough to go to community and follow up with their family doctor, they have to stay in hospital. So one of the things that the government and a lot of primary care networks are trying to develop are things called virtual hospitals. So it takes into account this whole virtual remote monitoring that we're trying to do to get patients out of the hospital, out into the community, but we still want to monitor them. We still want to look at their vital signs. We want to make sure they don't die at home if that's not what they want. And it's a good way to kind of raise some flags so that they can seek attention right away. Clinical decision support systems are in a process of development. I actually did like a very thorough literature search on them, and there's lots of preliminary studies on trying to create these support systems, but none of them are actually commercially available right now. The closest one that's commercially available is the one that TELUS Health is making, and it's not really an AI system. So it's a work in progress. Just some examples of some work that has been done in the past are falls in the elderly. So the other day I was working in the family medicine service at the Grey Nuns Hospital, and there was a patient that I saw who had a fall, and she actually fell at home and she wasn't found for another 36 hours. She lives by herself, and she has really good kids. They check up on her every day, which is actually better than most kids. But she fell at home, she fell off the stairs, didn't know what happened, and she was laying there for 36 hours before she was found by one of her daughters who came to check up on her because she didn't answer her phone call. So the reality of Canada is we have a lot of older people. A lot of those people are actually living independently at home, and there's no way to monitor them or make sure that they're safe. So there was this cool study by Albert and al. Where they tried to essentially, so they use support vector machines, which are arguably, like, I feel like the definition of AI is kind of constantly changing. I don't know if it's still truly considered AI, but there was a point in time where support vector machines were considered AI. And they essentially put this program into a phone so that when there is a rapid deceleration that's unlike any of the behaviors that the patient has, they would flag it and they'd call their contact person and say, there may have been an event. Could you check up on your loved one? So that's an example of a study that has been used for remote monitoring. There's another one. This one's a pretty famous paper. They used, I think they used convolutional neural nets for this one to evaluate breast cancer. So essentially what they did is they got two radiologists to classify breast cancer or not breast cancer. And then they trained that labeled data with this convolutional neural net. And then they tried to classify cancers as yes, there's cancer, or no, there's not cancer. So really great for screening, because screening is a really big part of primary care. Radiologists spent a lot of time reading these images of normal breasts when there's only about 1 in 1,000 that might be breast cancer and needs a biopsy. A similar thing was used for detecting lung cancer. So high-risk individuals who are smokers, they undergo screening, so CT scans of the chest because they're higher risk of getting lung cancer. And again, these are people who don't have any symptoms. They're just people who are high risk. We do these CT scans on them to see if they have cancer. And there are these radiologists spending lots of time looking at these screening CT scans. So having some sort of machine learning model that can do this in the place of a radiologist can be really helpful in our system. Again, just another example with dermatology. So there's kind of a dermatologist level classification of skin cancer using deep neural nets. Again, this is the whole kind of screening diagnostic pathways that we have in primary care. So these are kind of emerging technologies that we could potentially use and that would be very effective for use in Canada. In terms of remote monitoring, I didn't want to spend too much time talking about it, but there's this really great paper if you want to check it out. It kind of just looks at, it was just published a couple months ago, but it just looks at all of the different tools that have been created to remotely monitor patients. So these are patients who might be at risk, who just left the hospital, elderly patients, and just otherwise high-risk population. So that's my other domains of medicine. So we're going to move on to how to read an AI paper. This is just a general overview. And my disclaimer to this whole portion of this talk is the way you read a paper really depends on why you're reading it and who you are. So someone who is in medicine, who's trying to get a certain thing out of a paper will read it very differently from a software engineer or from a machine learning scientist who's trying to get another thing from the paper. But for general understanding of the paper, this is kind of just like a beginner entry level. Someone who has never read a machine learning and medicine paper will just have a general overview of it. I'll show a couple of papers. I don't have the links, but I do have like all the authorship lists and everything. So I'll just get you guys to Google it and work together when we're on those stages. So this is kind of a potential process that I suggest. The first step is just very basic. Just read the abstract and read the conclusion. Keep that in your mind when you're reading the paper, because it's really easy to get lost in the rabbit hole of reading machine learning papers. Second, we'll talk about the data and the machine learning methods, and then we'll talk about performance and generalizations, limitations, area of improvement, and then lastly, how do I feel about this paper, which is an important step as well. So first thing you want to do when you're reading a paper is read the abstract, read the conclusion, and just keep in your mind, what is this paper actually doing? Like, what is the goal here, and why are we doing any of this? And then just keep that in the back of your mind when you're reading the paper. So for the second step, I would say the first thing you need to do after reading the abstract and the conclusion is look at the data. What are we actually using? Hopefully you've seen this at some point in your machine learning journey. We always know whenever, like, the data is the first thing that you need to consider when you're doing anything related to machine learning. If you give it low quality garbage data, it doesn't matter how fancy your machine learning algorithm is, you're going to end up with garbage results. So the data is the very first step. You want to make sure that the data you're using is good data. And these are kind of like the three hallmarks of what makes data good. So in machine learning, it's really important to have lots of data. You need lots of examples. So that's the quantity aspect. You also want to look at the quality of the data. So what kind of, if we're looking at images, what kind of cameras are we using? What are we doing to make sure that the data is actually of high quality? If it's genetic data, is the data corrupted during the process? If they went through Illumina sequencing, are there any missing areas, or is there lots of noise? So what is the actual quality of the data? Then lastly, the diversity. Again, this is super important to have good representation of different groups. So again, depending on the study, you want a good representation of the different genders, the different ethnicities, the ages, different parts of the world, geographic regions, people analyzing the data. We want different people to analyze the data. So very important to have a good diverse data set as well. And just to kind of talk a little bit more about the diversity. So let's say we're trying to build a model and we want to distinguish dogs from other animals. That's all it's supposed to do. We are just like, yes, dog, or no, not dog. So if you gave that algorithm, let's say you gave it 300 images of dogs that looked like this and 300 images of not dogs that looked like this. What do you think would happen if you gave it a thing that looked like this? Do you think it would recognize it as a dog or a not dog? Exactly, because that looks pretty different than this, right? So if you don't have a good diverse data set of all of the dog species that exist, your model's not going to perform well. It's not going to recognize the other types of dogs. It's going to recognize this as a not dog. So just keep that in mind. The last thing I want to talk about in terms of data is how you split it. So in machine learning models, you always want to test it, right? So you're trying to create it, you're training it on a data set, and then you want to split that data set so that you can actually test to see what its performance is. So the most common way of testing it is by splitting the data as 80-20, so training and testing. Sometimes you'll hear that word, the validation set. So validation set is like a mini testing set. It's often used usually for neural networks to tune those hyperparameters, which I think you talked about in one of the earlier lectures. In other machine learning algorithms like latent Dirichlet allocation, which I don't think was talked about, you can just skip straight to the testing set. There are no real hyperparameters to tune. So if you read the papers, sometimes you'll see an interchange between validation set and testing set. And again, it just depends on which machine learning model we're looking at. So one example, if you ever looked at competitions like Kaggle and like hackathons, they never reveal the testing set to you. Like they'll just kind of give you this set of data and then you have to split it yourself. So that's an example of when you'd use kind of that validation set. So you would take the whole data, you would divide it, let's say as 80-20, the 20% is the validation set where you tune your hyperparameters, and then you test it on this testing set that you don't have access to, that only Kaggle has access to. And of course, there are different ways of splitting it. So 60-20-20 is a pretty common one. 50 for 50% training, 30% validation, 20% testing is another common one. It really doesn't matter how you split it. You just want to make sure that you have enough data in the training set to train your model properly. So I'm going to give you guys about 5 to 7 minutes. Try to Google this paper, and I want you to only focus on the data. Okay, so you're just looking at the data, and then we're going to go over those data aspects. So we're going to talk about quality, quantity, diversity, and then just how they split their training and testing set. And then we'll come back in about 5 to 7 minutes. And please talk to your partner and socialize, get to know each other. Link is also going to be on Slack if you have issues finding the paper. Okay, I'll give you guys 1 minute. Why don't you just talk to each other and make sure everyone's on the same page, and then I'm going to pick on some people. Okay, are you guys ready, or do you need more time? Who needs more time? We're good? Okay. Okay. So what number did you guys get? What's the quantity of data that was used to train the model? What did you guys get? Yeah, what was the data set size? Yes, amazing. Good job. So they had a lot of retinal images. How many patients were there though? Does anyone know? Brody, how many patients? How many patients? In the testing set? Or the other one? Okay. So the raw data set that they used for the images, if you look here, did you guys find this table? Did everyone find this table in the supplementary section? So if you look here, so this is kind of like what they started off with. Obviously, they went through some pre-processing, but the number of unique individuals was actually 69,573. So that's actually pretty good. So it's one thing that I really want to emphasize in machine learning papers. It's really important to look at how many unique patients there are. Because if you just have like 10 images of the same retina for one patient, that doesn't really count as 10 truly unique images. So always important to look at how many patients there are. So this paper is actually doing pretty good. What about the quality? How did they look at the quality? How did they assess the quality? You guys remember? Does anybody know? So they basically got the ophthalmologist to look at the images and just say whether or not they think it's of good quality. So obviously they gave them some parameters, but they made them kind of put on a scale of 1 to 7. So just keep that in mind. How are we assessing the quality? And in this case, they got 7 different ophthalmologists for each image to assess the quality. So again, that's actually pretty good. That's high quality. Did you guys find this information about diversity? So imaging tools, we're looking at images. We want to make sure that they're using different tools. If they're only using one tool, then we could potentially have a really crappy model if we use it on a different imaging method. So if they use a different camera, the tool might not perform as well. So in this case, they actually use several different cameras, which is great. For imaging techniques, this is kind of ophthalmology specific. 40% of them, they actually did dilate the pupil, whereas 60% they didn't. So that could actually cause a lot of problems if you don't have that kind of diversity in your data. And then for locations, mostly US locations, but different US locations. And then they also had 3 locations in India. So that's pretty good too. In terms of the actual patients, the mean age was 55. Standard deviation was 11.2 years. So that might be a little bit difficult when you're assessing younger patients with type 1 diabetes. So something to consider in limitations. For gender, a pretty good split, about 60% female, 40% male. And I didn't see any mention of ethnicity. Did anybody see anything about ethnicity? Okay. The data was labeled, you remember, with 7 to 8 ophthalmologists. So 7 to 8 looked at each image and tried to say whether or not it had any type of referable diabetic retinopathy. They basically just used the majority. So if there were more than 50% of ophthalmologists that said, like, yes, this is diabetic retinopathy, then they referred it and they called it as a 1, like it is, this is referable. How did they split their data though? Did you guys look into that? How did they split their data? Avoiding eye contact. Yeah, how did they split their data? Yeah, exactly. So they did something that's actually a little bit unique. So what they did is they actually didn't split their training set. Their validation set was actually their testing set, and it was a completely separate data set. So one of them was this IPAX-1 validation data set, which is US based, and then the Messidor 2 validation data set, I think it's from France. So their validation set was actually a completely different data set, which is pretty cool. That's a pretty unique thing to do. Any questions about data? Yeah. Mm-hmm. Yes, like if they were to split the training set. Mm-hmm. That's correct. Yeah. So the question was any of the images in the testing set involved or a part of the training set?
That's not going to work. You're essentially telling the program, is my picture inside this data set.
Exactly. Yeah. So whenever you're using any validation set or any testing set, you never want to expose a training process to it. The only exception to that is when you're doing K-fold cross-validation, which I don't know if anybody's heard of it, but it's just like one technique where you basically mix up the validation set with a training set to find the best hyperparameters for a neural network. They did. So the question was, did they mention how they took the pictures for the data? And I believe they did in the supplementary section, but it wasn't super detailed. They talked about the different devices that they used. Things like that, or the other kind of messed it up. So that's kind of important that there's like certain standards between medical pictures. So if those are kind of violated, then the whole data set is compromised. So I would actually argue against that. So in reality, there are some low quality images that can be used, but if those images have to be diagnosed, like a diagnosis has to be made on them, we'd want an algorithm that can actually kind of rule out the artifacts and just try to make a diagnosis, because that's what experts do today. That's like what the ophthalmologists would do. They would say, oh, I think this is an artifact, but the real thing that's happening in this picture is there's these cotton wool spots, and that's a sign that there's diabetic retinopathy. So a really good, well-trained model would be able to recognize the artifacts and would be able to adapt to low quality images potentially, or images taken by different devices that are not the same. Okay, yeah, no worries.
So let's say the strongest one is weight of 1, and the lowest one is like a weight of 7 or 8, whatever.
Like the nodes in like the neural net?
How confident they are that this is diabetic retinopathy. So if they would assign a number, let's say they're very confident, so they would assign number 1, and then they're the least confident they are, they would assign it like number 10.
Oh, I see what you're asking.
So like there's some sort of standard as to how they're rating retinopathy. Like what's the criteria?
Yeah, that's a great question. So the question was, what's the criteria? How did they grade the retinopathy? So it was different from the quality. So the quality was the 1 to 7 scale. There is, I think I took a note of it somewhere here. Let's see. So ophthalmologists have to follow guidelines. So they have to go through kind of this process of like what actually is diabetic retinopathy? Like, how do I even recognize this? So there is a scale called the International Clinical Diabetic Retinopathy Scale, and that's what they use. And they don't use confidence intervals for that. It's just if they satisfy certain criteria and it's above that threshold, and they say, yes, you have diabetic retinopathy, or you should be referred for further assessment. So that's how they do it in medicine. So that's how they train this model to kind of reflect our current medical practices. Okay, if you have any other questions, we can talk. We can talk at the end. Any other questions about the data? Okay, great. So let's look at the machine learning methods. I'm not going to spend too much time doing this because I feel like this whole course was kind of geared towards looking at the different machine learning models that exist. Just kind of some general categories that you're considering when you're evaluating an ML paper is which category does it fall into and what limitations come with each of those categories. So some potential categories would be like supervised machine learning, unsupervised machine learning. There's something kind of an in-between called semi-supervised, reinforcement learning, transfer learning, deep learning, so transfer learning is a little bit of a deep learning. And again, considering how this affects the performance. So what kind of AI is ChatGPT? What kind of AI is it? Is that deep learning? I think that's a type of deep learning. Awesome, great. I wasn't smart enough to figure it out, so I just asked ChatGPT. So it's deep learning. So can you have, so let's say like we have these categories. Can you have a supervised machine learning model that is also a deep learning model? Like, does that exist? Yes, right? So all supervised is saying is that we're labeling the data. We're basically telling it what the categories are in the training set, and then we expect it to perform accordingly. So whatever, like you can have a deep learning model that uses labeled data. So that's a supervised deep learning model. Okay, good job, everybody. So when we're looking at this paper, what kind of machine learning model are we using? Yeah, it's supervised deep learning, right? So it says deep learning right here. So that's good. We got number 1. We also had a chance to look at the data and we know that it's labeled. So it's supervised deep learning. I think we're kind of getting close to the end. Otherwise, I would have made you guys go into this paper and look at things. But this cancer screening also uses deep learning. And it's also another example of supervised deep learning. So they labeled the data and then they put it through this deep learning machine learning model. Okay, so now we're here. We're kind of at this performance and generalization step. There are lots of different performance parameters that can be used in machine learning. The first thing that I want to talk about is kind of the basis of how we look at all of these different performance parameters, which is sensitivity and specificity. So Sensitivity is really good at identifying people who have the disease. Okay, so if you have 100%, if you have a model or a test that is 100% sensitive, it's going to catch every single person or every single patient with that disease. Okay, for specificity, it's good at identifying those that don't have the disease. So a test that's 100% specific, or a model that is 100% specificity, will be able to correctly identify all the patients that don't have the disease. So I like to visualize things kind of in this way. So let's say all of the red dots, they're people with a disease. So let's say the disease is breast cancer. Okay, so everybody with a red dot has breast cancer. The plus represents whatever they're labeled as. So if they're red and they're plus, that means that they were correctly identified as having breast cancer. If they have a minus, it means they're incorrectly identified as not having breast cancer. They have breast cancer, but the test said that they don't. So something that's 100% sensitive will catch all the people with breast cancer. It won't miss a single one. A test that's only 20% sensitive will only catch 20% of patients, and it'll miss 80% of breast cancers. So this isn't the best test. This is a pretty good test. For specificity, you want to rule people out. You want to say, I'm sure that this person does not have breast cancer. So all of these greens are normal patients with not breast cancer. And the minus is they don't have breast cancer. They're correctly ruled out. If it's positive, it means they're incorrectly told that they have breast cancer when they don't. So a test that has 100% specificity, you're correctly identifying all of the patients that do not have breast cancer. You're not falsely labeling anybody. But a test that's 20% specific, you're only correctly identifying 2 of them as not having it. So that means for 80% of patients, you're telling them they have breast cancer when they actually don't. So this is really important in medicine. Ideally, we want every test to be 100% sensitive and 100% specific. We want to identify absolutely everyone who has breast cancer, and we want to absolutely identify everyone who does not. But of course, these tests don't exist. There's always some sort of drawback. Either you're taking away from sensitivity or you're taking away from specificity. So for example, if we have a test that's 100% sensitive, but 50% specific, you're catching all the patients with breast cancer, but it's 50% specific. You're falsely telling people that they have breast cancer when they don't. Does that make sense so far? Are you guys following me? Okay. The other way around would be something that's very specific and not sensitive. So it's 100% specific. It identifies all the not breast cancers with 100% specificity, but it's missing a bunch of people with breast cancer, 50% of them. There's 50% of people who have breast cancer where you told them that they don't have it. So usually whenever we talk about sensitivity, we're always talking about specificity, and we're always looking at the 2 together when we're deciding how to use diagnostic tests. So the area under the receiver operating characteristic curve is one of the methods that they kind of try to talk about sensitivity and specificity in machine learning. So essentially the 50% line is just like it just didn't do well at all. So the more towards the left that the curve is, the better the test is. So it's generally used for binary classifications again. Okay, so it's either you have it or you don't have it. And it measures the ability of the model to distinguish between the positive and the negative examples between the different thresholds. So that's why it's from 0 to 1, and the higher values indicate the better performance. So here on the y-axis, we have sensitivity. So that's the probability of the true positive with the test positive. And then this 1 minus specificity, it's the probability that a true negative will test positive. So it's falsely labeled as positive. So if you're ever looking at like the AUC, ROC, just remember larger number is better. Mean squared error is another one. This is good for just things like logistic regression. Like you just want to make sure that your line is kind of correctly, it's kind of going as close as it can to the data points. So I think I have an example coming up. I'll show you guys an example of this. And the last one is confusion matrices. So these are also used a lot in machine learning. And if you look here, so actual values That's like what the patient actually has, and the predicted values, what you predict. You want basically this axis to be like 100% and this axis to be 0. So there's no false positives and there's no false negatives. You want everything to be true positives and true negatives. So in this example, I won't make you guys read the article, but when there's this machine learning article on different classifiers for automatic age estimation. So they used a few different ones. They used this quadratic function and then the shortest distance. And they looked at the mean square error. What am I looking at? This is the wrong table. Sorry, guys. So anyways, limitations and areas of improvement. I think we have 10 minutes. So always look at the data. Whenever you're assessing the limitations of a paper, you want to take a look at the data and think about all those things that we talked about. Do we have enough data? Is the data of good quality? Do we have enough diversity in the data? In terms of overfitting and underfitting, we didn't really go into too much detail. I think it was covered in a previous lecture though. Essentially, we don't want a model that's too simple, that doesn't explain our data very well. And we also don't want this like hyper fit model that tries to explain every single data point, but is not generalizable. So if we look at this kind of like overfit example, it's kind of like, let's say we're trying to fit these points with a quadratic function. We're trying to get as close as we can to predicting the values. And then when you start to overfit, your model basically warps to fit the data perfectly. And you end up realizing that this isn't as good because if we added some data points, that overfit model will actually not perform as well on the testing set as a properly fit model, like in this case. Explainability is debatable. So some people think that in medicine, in order for your model to be used in clinical scenarios, we need to explain why it makes the decisions that it does. But this is a topic of debate, so I won't go into too much detail in this one. Another one is computational resources. So if your data takes 3 months to train and it takes however much time and computational power to give you a result, that realistically might not ever be practical in a setting that's clinical. You need to be able to use the resources that you have to make the predictions that you want to make. And that's pretty much it. And now we're at step 5 of how do we feel? And I always add this one because I think it's important to think, like if you're still skeptical of a paper, like if you wouldn't use that tool, you really need to ask yourself, why is that? And what could be done to improve the paper so that I do trust it? And if you feel really good about it, then that's probably a good sign. Hopefully you actually looked at all of the potential areas of improvement and you feel like they did a good job and you would trust using this machine learning algorithm on your own mom. So the how do I feel step, I think, is an important addition to evaluating an ML paper. And that's the end. This was supposed to say questions, but I forgot to write questions. So we do have 10 minutes for questions. If you want to come up and talk to me or just hang out, I will be here for the next little bit. Thanks so much for listening.